Good morning, everyone. I'm Dr. David Wild, Vice President of Performance Improvement here at the University of Kansas Health System. Chief Medical Officer Dr. Steve Stice is off this week. We're coming to you from the Dolph Simons Jr. Family Broadcast Studio. Our guest this morning is going to help us answer the question, does COVID-19 cause diabetes? Dr. David Robbins, Director of the KU Diabetes Institute, is here at the health system, will react to reports of an uptick in new diabetes cases since the pandemic, and we'll meet one of his patients, George Beck. But first, Dr. Dana Hawkinson, our Medical Director of Infection Prevention and Control, is here with our numbers. How did we do over the weekend, Dana?
Yeah, I think we're still doing well, despite the United States seeing a slight increase overall in cases. Here at the health center, at the health system, we have 8 active patients with 2 in the ICU and 1 on the ventilator, still 15 in that recovery period, so still a fairly low number, and Hayes has only 1 active patient as well. We thought those numbers were climbing up over the past 2 or 3 days, certainly getting in the double digits for active infections. But we're pretty happy with this.
Yeah, I like 1, even if anywhere. 1 Hayes, 1 here.
I know.
And less than 10 here. Again, it's sort of the normal variation we've seen, bouncing back and forth between 5 and 15.
And I think until something happens, whether it's new variants, unknown variants that we don't know about, I think we'll probably stay in this maybe 10, 5 to 15 range for active infections at any one time for the foreseeable future. So get more vaccination out there. That'll help, although.
Absolutely. Before we jump into our conversation today, are there any reporter questions on the line?
Hi, good morning, guys. It's Taylor, Channel 41.
Hey, Taylor.
So, obviously, with Kansas going in, both Kansas and Missouri going into new phases today, but with Kansas going into the phase 5 where every adult is eligible, I'm curious about if you have an opinion on best practices of attempting to get an appointment, and say once I have one, is it good to continue trying to get one even closer to me? Because people are going to try to get these as soon as they possibly can. Is it best that once you have one, just stick to that one, or is it better practice to, hey, I'm going to keep trying to see if I can get 1, 2, 3 days even earlier than that, or does that gum up the system?
Well, I think moving or having multiple appointments and only keeping one of them definitely causes challenges for us as a vaccinator. We've actually not seen too much of that so far, though. As we talk to our patients, for example, who are over 65, who had not been vaccinated yet, we started calling those that didn't have an appointment. And what they told us was, we've got an appointment somewhere else next week, and we're just fine to keep it. We've done this for a year, 5 more days doesn't matter. And I think that's an important distinction because, there's not an immediate benefit. It's not like you get your vaccine today and in 6 hours you're completely immune. And so 2 or 3 days difference probably doesn't matter much for most people, and it definitely helps us not have to scramble at the last minute to make sure we have enough people to fill all of our appointments so that we don't have wasted vaccine at the end of the day. So my advice would be, if you're talking about a couple days difference, I don't think it matters much. If you find that you can get in a week or 2 earlier somewhere, that's probably a good thing to consider, but just make sure that you let the place that you were scheduled first know that you won't be coming.
So Shane with KSTV5 sent a question this morning, and we prepared a graphic for it because they had a lot of numbers in it. And he writes, hey, I'm just crunching the local numbers. It looks like we're seeing a significant increase in hospitalizations in much of the metro. And he said, are doctors worried about an oncoming surge? What reasons could there be for these numbers, and what should we do? And if you look at some of the numbers, Clay County, hospitalizations up 23%, Johnson County, 19%. Jackson County, 18% plus. Those are the 3 biggest.
Yeah, so I think if we think about what we've learned over really the past year, the first thing I would say is in any time frame, there's variability from community to community. There tends to be sort of local swings in the numbers due to local transmission. And so while it may not formally be a cluster at a business or a school or a nursing home, for example, that there becomes sort of this group that's transmitting inside a population, say in a county in this case, and leads to some variations from 1 week to the next or even 1 month to the next from place to place. And none of those individual numbers scare me too much. I think the overall look at Mark and an increase in the percentage is maybe a good sense that we're a little bit different than we were a week or two ago. But we've been saying that for several weeks now, actually, that we're seeing an increase. And the other thing that's interesting in all of this, what we're learning out of Michigan, for example. So lots of questions over the last couple of weeks about how cases are increasing, and at a significant rate, maybe 30 or 40% more new cases each week than the prior week for a couple in a row, and that's a very real increase in cases. But the staggering number was that hospitalizations are doubling. So much greater increase in hospitalizations than new cases. And what's that related to? Because we haven't really expected that any of the variants that are in play in Michigan, for example, are causing more severe disease, just more easily transmissible disease. And the thought that explains that probably the best is that those with mild symptoms are not being tested. And so we're not finding a lot of the mild or asymptomatic disease that's sort of spreading in the community, say in Michigan. And the real marker of disease or its transmission rate in that community is the hospitalizations. And so if we were to test a broader swath of the population, for some reason we would find that the cases are increasing sort of at the same rate as the hospitalizations. So with that in mind, the reason I bring it up is this becomes a very interesting question and actually very important. What's happening with hospitalizations? Because we've known that hospitalizations and deaths are the things that don't really change. The definition of death is not different from state to state or month to month, and those reasons for being in the hospital, at least for the past 10 or 12 months, haven't changed dramatically. Maybe early on we were admitting some people who just needed a little bit of oxygen who wouldn't be admitted now, but for the most part, hospitalization reasons haven't changed. And so question is great. For me, all I see in those individual numbers right now is a little bit of variation and maybe some local dynamics, but of course we'll keep paying attention. I don't know, Dana, other thoughts?
Yeah, I think that's a good point. We did have our CMO call last week that you were on, so it's the chief medical officers of all the major hospitals and health systems around here, and everybody was fairly happy with the amount of total hospitalizations that they had at their facility. And again, that was a week ago. I don't think it's just those numbers because, if you have an increase of 10%, if you have 10 people in the hospital, that's one more person. But if you have 110%, that's a lot more as far as pure total numbers. So I think just to your point, I think you have to take those numbers in conjunction with the local infection dynamics, but also the total number of people as well. So,
all right. Any other reporter questions on the line this morning?
I think you're good to go.
All right. Well, Dr. Robbins, scientists around the world have noticed an uptick in new diabetes cases last year during the pandemic. The journal Diabetes, Obesity, and Metabolism found that up to 14.5% of people hospitalized with severe COVID-19 also developed diabetes. So the appropriate question, I think, is, does the SARS-CoV-2 virus cause diabetes? And if not, what do we think is happening here?
Well, we don't have the answer to that. I think that the vast majority of studies and the experience in a variety of countries has shown that there is a very high uptick, interestingly, both in the adult or type 2 diabetes and also reports of type 1. One explanation may be that when someone just gets sick, it brings out the tendency that they were either pre-diabetic or it pushes them over to diabetes that they would have gotten anyway. But there's some very tantalizing data. There are some receptors for the COVID virus in the beta cells that make insulin. And it also produces a very high inflammatory state that may wear out the pancreas. But there's a number of issues that have yet to be resolved. But it is indeed true we're seeing a lot more diabetes now post-hospitalization.
You mentioned type 1 and type 2.
Right.
Refresh us just a bit on the differences and why that may be important in this conversation.
Yeah, so the majority of Americans have type 2, which is usually onset in middle age, usually has an insidious onset. It slowly comes on and doesn't always need insulin. Type 1 is typically seen in adolescence, which has an explosive onset and almost always requires insulin, and represents about 5% of the diabetes burden in the United States.
So you mentioned inflammation, or this inflammatory response may sort of set off the pancreas. As you're understanding the receptors that may play a part in this conversation, Do we think that the blood sugar regulation and this new diabetes and potential requirement of insulin, is that a permanent thing?
We don't know. What we do know is that there is some good news in this, and that is that people who come into the hospital with lower blood sugars are less likely to have complications and have a shorter stay. Certainly the vaccine works extremely well in diabetes, so we're encouraging all of our patients to get that as well.
Yeah.
So we know that diabetes has been a risk factor for severe COVID disease. And we also know that COVID has been, for those who've had an infection, has been hard on diabetic patients. Before we hear more from George about his experience, tell us how COVID affected him from your perspective, and a little bit about how it changed his diabetes from where he was before his infection until after.
So, having an illness when you're taking diabetes is always a challenge because the body becomes more resistant to insulin, and as part of the response to stress, you have a high blood sugar, and staying on top of that is always a challenge. In addition, with COVID, it adds to the overall inflammatory response that is the big problem with the disease, and can have lingering effects after the acute phase is over, reducing the amount of exercise, causing shortness of breath, heart problems, and stroke, just like we've seen in the general population.
Yeah.
Thanks. So George, thanks for joining us and for sharing your story. Tell us a bit about how you're feeling today.
Well, I'm feeling pretty good today. I'm still, like Dr. Robbins said about the lingering effects. I still have tightness in the chest, shortness of breath. If I, stand and talk for quite a while, I'll start to lose my air and need to just have to stop and take a deep breath or, a couple of breaths to get to going. When I acquired, I guess you could say, the virus back in January, there was about 4 days that I actually thought I was going to die. There was just a big pressure right on my chest, and I couldn't hardly breathe. I couldn't, sitting up, I couldn't breathe. Laying down, I couldn't breathe. And so I just, suffered through it or was able to go through it. And that, has progressively gotten less and less up until about 3 weeks ago. It just kind of leveled out, and I've just kind of stayed where I'm at right now, walking maybe 3/4 of a block, and I'm winded. I'm stopped. When I'm dealing with my students, they kind of look up at me kind of wide-eyed and say, "Are you okay?" And I say, "Yeah, just give me a breath, and I'll be back at it." So, that's where I'm at right now.
You mentioned you're a teacher. Tell us where, and if you're back in the classroom.
Yes, Hutchinson Career and Technology Academy. It's here in Hutchinson, Kansas. And yes, we are in the classroom. We're going. Mainly, we're out in the shop. I teach students how to build buildings, commercial trades, that type of stuff, carpentry. And we're out going. It's nice.
Excellent. You mentioned that you had COVID in January.
Yes.
Do you know how or where you were exposed and where you think you actually became infected?
Well, I kind of want to blame my daughter, but don't tell her that. But she was diagnosed, a day before I was, and then the rest of the family, when they went in and got tested, they all tested positive too. So I can't, exactly say that it was her, but she was the first one, so I'm going to blame her.
Wow.
Fair enough. I heard you had questions about the vaccine. And despite your troubles with continued symptoms and other impacts of the disease, you might have been a bit hesitant and asked a lot of questions. Did Dr. Robbins convince you to get your vaccine?
Well, Dr. Robbins, I look up to him because he is a professional and I trust him, and he's, convinced me to go ahead and get the vaccine, although I haven't done it yet. But has he answered all of my questions or relaxed everything down? No. I'm still anxious about, what the long-term effects of the vaccine is. In my past, I know this may not have any correlation to it, but it does to me. In my lifetime, I've had 3 flu shots, and every time I got the flu shot, I got the flu, and it wasn't just a little case; it was a pretty heavy case. But other than that, I don't really recall getting the flu, and this vaccine kind of goes back to that memory of getting the flu pretty hard. Even though I've already had COVID, I just there's just that stigma or just that thought process of if I get the vaccine, what is going to happen? And if I have to go through what I did back in January, man, I don't know. That just scares me to death to do that. But I'm probably going to go ahead and get it here, within a few weeks or whatever, whenever I can.
Well, I think, you outline what many patients have voiced to us as very, very real concerns. And as you mentioned, while those experiences in your past with the flu shot, for example, may or may not be related to the vaccine, they definitely have a relation for you. And I think the relationship that you describe with Dr. Robbins and the importance of that, right, that you have someone who you trust, who is invested in your care and is providing you the best information that we have around the guidance about impacts for you, will remain very, very important in making sure that you feel comfortable in how you move forward with that decision. I know all of us around the table have a lot of reasons why we would encourage you both to continue that relationship and to move forward with your plans for vaccination, but definitely understand your concerns.
Thank you.
Jill, let's jump into some questions from the community this morning.
Yes, we have some, and they're good ones. The first one I'm going to do is Marcy, just because of the vaccine question. She says, does a vaccine help with long haulers like George and their symptoms, that she has heard stories that's true?
Dana, you want to start?
Yeah, I think that is a question that we are investigating, and we meaning the medical and scientific community, because we have heard those stories. We really don't envision a mechanism for that, but I think they have been really popular stories in the media, and it's more than one person. And so I think if this is one more aspect of maybe treatment or minimization and reduction in those long-haul symptoms, I think that is one more reason to go ahead and get the vaccine. So that is a question that is being thoroughly investigated and data being collected. It would be good to have an absolute answer for that, but I'm glad for those people that do have long-haul symptoms have gotten the vaccine and had a reduction or really resolution of their symptoms.
Dr. Robbins, have you seen in your practice any patients post-infection that have a vaccine and come with those sort of feelings that they're improving after their vaccination?
Yeah, in fact, George and I had a very cautious discussion when I saw him last week about it may be true and maybe one more reason to jump on the bandwagon and get the shot.
Excellent. All right.
And that was Mary's question for you, Dr. Robbins. She wanted to know what the research has been done on that related to diabetic patients in particular. Has there been?
Yeah. Not specifically yet. I haven't seen anything come out. It's too new.
Michael wants to know from George, how did the rest of the family fare? How'd your daughter do and everybody else with the disease?
Yes, great questions.
Well, my son, he had a headache for about half a day, and then he was done. My daughter, who came down first, she was sick for probably about a day, where she, had the flu symptoms and upset stomach and headache and stuff like that. My wife, on the other hand, she tested positive, didn't miss a beat. It was a good thing that she was up and available to, be the nurse of the house. She didn't have any symptoms whatsoever, at least not that I noticed, and not that she told me. So I don't know why it all singled out onto me, but I guess I deserved it.
Not so sure about that, but yeah, lots of questions from families about those things, where one maybe of a family of 3 or 4 really has very, very few symptoms, and then the others in the family have differing degrees. And so that's not a surprising story. I guess in some ways I'm glad that the whole family wasn't ill at the same time, really, to the degree you were, but I'm sorry that you were the one that got singled out.
I don't know if it was because of my age or the diabetes that, really socked it to me, or just a combination of both. I don't know.
Yeah, we know both those things are risk factors for more severe disease, so very well could be the case.
Charlotte is curious if George and the family wore a mask and if they're masking at school.
Yes, we are masking at school, and yes, we did wear masks. We do wear masks. Right now, I don't have a mask on because I'm in my office, and the students are out there with another instructor going. But yeah, we have masks. I have mine right here. On the mask, I don't see it. Oh, right here. I have this little, I don't know if you can see it from where you're at, but this helps hold the mask away from my face to where I can breathe. Yeah. Otherwise, when I wear just the mask itself, I have a hard time breathing. Even with this on, I have a hard time breathing, but that helps me quite a lot.
We've seen lots of nifty little devices, I'd say, to help with things like that, whether it's around the ears for people who aren't used to wearing ear loops all day long. For those of us who've maybe spent a lot of our career in the operating room, we don't notice those things anymore. But for people who this is really the first time for prolonged mask wearing, those little devices make a big difference. And I'm glad that you found something that makes it much more tolerable for you, even if it's not your ideal just yet.
He may have to share where he got that. My husband would love that little device.
Yeah, Jill's looking for a source there, so someone will get in touch, George.
Yeah, I don't know if that was an Amazon find or what it was, but that's pretty cool.
Yeah, it was.
Okay. Isaac wants to know, do you anticipate a new vaccine supply crunch in the coming weeks due to it now being open season in Kansas?
So I have a lot of conversations daily, actually, about what vaccine supply looks like, what these changes in phasing and availability are going to mean for how someone can actually get into a clinic, or how long it will take to get a clinic. And I think those questions are good ones. There's no specific answer at the moment, but here's probably the best answer that I can give you. We've seen over the course of the past 2 or 3 weeks a couple of things that have led to more doses being available here, at least for our patients. One is that as we were wrapping up phase 2 and moving to the phase 3 and 4 here in Kansas, some counties were actually reducing their order, if you will, from the state, the number of doses they were requesting. But the state was still getting the same, and actually a slightly increased number as inventory became more available. And that meant that those sort of unordered doses that were allocated originally to counties that didn't need them could go to counties who could accept them. And so we've actually seen a much easier time getting doses of vaccine in the last week or 2 than we have for a month or more. So that's good news. And I think that some variables like that will continue. Of course, as we open wide, if you will, to everyone 16 and over in Kansas, it's likely that more counties will say, please send us our order this week, and so we'll see some of those dynamics change. But we also know that we're seeing more in the way of actual inventory coming in from the federal government and sort of continued improvements in the supply chain. unfortunately, I don't think that those things will add up to more vaccine than we have demand. And I think that it will actually be, for a period of time, maybe a little bit harder for someone who's really, really looking to get a vaccine, to get an appointment scheduled for a week or two here until we figure out how all of those things shake out now, like it took us a week or two to get figured out phase 3 and phase 4, or really towards the end of phase 2. But I'm not worried that we'll not have doses coming in, so that's good news. We sort of know how many to expect and what the supply chain is able to provide. And so we'll keep working within those constraints, but we do expect that it will be a growing number every week, at least relatively so, over the next couple of months until we can really work our way through the rest of the adult population sometime into the summer here.
Yeah.
Sue wants to know how dangerous diabetes is and what the symptoms are, and when should a person seek care?
Great questions.
Yeah.
Wow, there's a lot there.
Yeah.
The recommendation is that if you have close family members with diabetes, you should get screened yearly. During pregnancy, you'll get screened every trimester. The symptoms can be insidious, or they can be rather explosive. Urinating a lot because your body is not able to hold on to sugar properly, drinking heavily to try, drinking water and fluids to try to compensate for the water loss, weight loss. Those would be the classic symptoms, but in fact, the majority of people are discovered incidentally. They come in for their yearly physical, or they come in for a gallbladder operation, and they find out that they have diabetes.
Or COVID.
Or COVID. Yes.
You know, I'd like to add, too, I think for our general, pre-COVID, in the context of COVID, after COVID, diabetes is a mainstay of the underlying process that leads a lot of people to hospitalization. It's certainly for my practice, whether it's, foot wounds, leg wounds leading to surgeries, amputations. It's my cardiovascular colleagues and heart disease and peripheral arterial disease. It's our kidney colleagues leading to renal failure and needing a dialysis. So it is very prevalent and a underlying process in a lot of these disease processes that lead to medical care and hospitalization.
Yeah, and the statistics have suggested that diabetes is a very high risk factor for ending up in the intensive care unit, and some ICUs have said that the majority of their patients are diabetic. So it's way out of disproportion of what you would expect.
All right. Linda says, my friend had COVID the end of January, beginning of February. Should she get her shot now?
Yeah.
Yes.
Short answer is yes.
Yes.
Okay. Kristen says, when will we know if we need a vaccine booster? How long are these shots lasting?
Lots of good questions today. I think many of us still anticipate, for one reason or another, that it's likely that we will see at least some sort of yearly booster, if not booster in the sense of booster to regain immunity, booster in the sense of adding adding protection or control for new variants that may be out there. And I think that part of the conversation remains important, that as long as there is continued transmission of disease, that transmission and viral replication is where mutations happen, mutations cause variants. And so unless we're seeing very, very low levels of infection worldwide, really, then we're at risk of this continued process of new variants popping up, some which may be or may have what we call immune escape from the existing immunity caused by natural infection or immunity caused by vaccines. And so that process is probably the most likely reason in my mind right now for needing a more frequent, if you will, yearly or maybe more frequent than that sort of booster update. But we also know that we don't have long-term natural immunity to coronaviruses in general. And Dana, that's much more your world, but there's probably something to be said there too.
Yeah, I mean, I think starting at a year is good. Even with the new variants, we understand that it's not just about the antibodies that we are able to produce from the vaccines. It's also those T-cell responses, and there is more information saying that those T-cell responses may be more conserved even when you take the context of the different variants. But I think we are still all probably anticipating a yearly booster. We also do know that the immunity garnered by immunization, either prior to having COVID or even after COVID, looks to be much more efficacious, looks to be higher than people who have had COVID alone, including especially those people with asymptomatic or very mild disease. So.
And this idea of sort of targeting strains or picking individual variants to target with a vaccine, that's not new. It's sort of one of the questions I think that came up in George's story about his influenza vaccine is that the influenza vaccine is actually a little bit different. We try to guess which strains are most likely to cause infection worldwide each year and package them into a flu vaccine before the flu season. So that's how the influenza part works. But right now, a yearly booster for COVID would likely be more in reaction to those new variants that show up, I think. Does that make sense? Yeah,
absolutely. And we know that it's fairly easy for those mRNA vaccine companies to pivot, possibly even for, say, the protein companies if Novavax does get emergency use authorization. Maybe a little bit more difficult for Johnson & Johnson, AstraZeneca, just because of their process, but they are still able to do it as well. So all of those companies are able to do it, and just like you said in influenza, we know that is a common process that has to happen every year as well. My concern is that we have such extreme low levels of influenza right now, as did the Southern Hemisphere before us, that will continue. So hopefully people will not let down their guard against influenza, because my concern is if we do that, people don't get vaccinated, that we really could have a huge surge worldwide of influenza as well, because we aren't really seeing that in the community for unvaccinated people, and also people are not getting vaccinated against influenza.
Great.
But right now, everything really looks good. So we need to continue the infection prevention measures, masking, hand hygiene, distancing as much as possible, really get COVID to decrease a lot further, and then we can start talking about the other issue.
Donna with Channel 9 wants to know, George, are you a type 1 or type 2 diabetic?
Well, mine was diagnosed, middle age, so I believe that's a type 2. Although I don't develop any insulin, so I'm on a pump and I take a lot of insulin every day.
Stephanie wants to know, what does COVID do to people that have diabetes if it affects the pancreas, and why are type 1 diabetics on the list? Why do they get COVID?
Wow. Well, there have been reports of a new onset of type 1 a month or two after the infection. We've seen that with other viral infections. One issue is that this is just a nonspecific inflammatory response that tips people over the edge. But on the other hand, there are a couple of specific receptors on the beta cell that allow entry of the COVID virus into the beta cell and may destroy it. So all of that is still unknown with a lot of theories, but we certainly are seeing reports of an uptick in it, and there's a lot of investigation trying to find out why.
And then her first part of the question is, why is COVID hard on people with diabetes? How does it affect them?
Well, as I said earlier, any illness causes stress and increase in insulin resistance, more insulin requirements, and more attention to the diabetes. But in addition, even before a diabetic patient comes down with COVID, they have a high level of inflammation, particularly if they're hypertensive and obese. So when you get the COVID vaccine, the whole inflammatory response rises, and that appears to be the trigger of the multi-organ system failure that we often see in the people that get very sick with COVID.
And Christy wants to know, are we seeing an increase in just type 1 diagnosis from this COVID, or both?
Both. Mostly type 2, but both.
And is it permanent?
Well, we've tried to address that, and we don't know. Looking into the crystal ball, I'd have to say some of it is, but we don't know for sure.
Barbara wants to know, George, is everybody in your family going to get the vaccine with you?
We'll probably do it individually. Everybody kind of has their own thought process. But yeah, we'll eventually get it here in the next month or two. So one thing, when Dr. Robbins was talking there just a little bit ago, when I came down with the virus, I was prescribed some medicine to help relieve the pressure or help me breathe. And I think one of those things that I was given was a steroid type pill or something like that. That right there shot my blood sugar up and kept it up, and what made it very difficult for me to get it back down. So I was dealing with, a rather high blood sugar, in addition to the lack of breathing. So it kind of compounded and jumped on each other and just kind of made everything worse and worse and worse and worse. That to me was scary.
Yeah, thank you for bringing that up, because we use a lot of steroids in the hospital when people get sick, and that causes extreme insulin resistance and really makes the situation much more challenging.
Yeah.
But what do you do? I mean,
Well, yeah, so it's this balance. It's a constant balance, whether the disease is COVID or some other reason to need steroids. As Dr. Robbins mentioned, physiologically that means much more insulin resistance and much more insulin than is the treatment.
And part of the challenge is that statistically people who have the higher blood sugars in hospitalization seem to do worse. So we're on the one hand making the sugars go up by the treatment, but at the same time trying to keep the sugars down because it may have a prognostic impact, getting a better outcome.
One of the mainstays, regardless of the disease, in critical care management is tight glucose control, even if the patient's not diabetic. And so for those that are, and for those that have for those that receive medications or treatments that increase their insulin resistance or their blood sugar, that it sort of becomes this vicious cycle that we fight all of the time. I don't think people maybe think of the pancreas as often, and maybe the general public as this giant hormone factory of multiple sorts, and whether that be enzymes that help in digesting food, or this whole, insulin resistance, blood sugar management piece, stress response. I mean, it's a really complicated system. And that's about as much as the anesthesiologist can say about the whole process. But it's the reason, right? There's an entire specialty of study of the pancreas. I mean,
absolutely. There's general endocrinology, and then there's some of us in that field that go on to just focus on diabetes. There's so much of it in the population, and it's a very challenging disease to live with and to take care of it.
Let's do 2 or 3 more questions real quick. When Debbie says, what are the demographics of those who have developed diabetes during or after COVID?
That's a great question. It unfortunately affects people of color and minorities more often than Caucasians and upper middle class people. So and we don't know there are theories, but with the real underlying reason, whether it's genetic, biological, or whether it's because people are just in poorer health to begin with, are really some of the questions that need to be addressed.
Cecil wants to know, what can you do, eat, whatever, to avoid getting diabetes later in life?
There's 2 things you can't change. You can't change your genetics, and you can't change the fact that you're getting older every day, which are risk factors for diabetes. But you can stay thin. You can exercise. Those would be the top 2 things that I would say is stay fit. And under those circumstances, you may reduce your risk as much as tenfold.
Important, I think, in that conversation, you mentioned the sort of disproportionate impact in people of color, or even potentially socioeconomic status. When food quality, food quality or food scarcity are part of the equation, and obesity is already an issue It really is hard to manage those things in an area where you don't have a lot of resources to that extent. And so obesity and lack of exercise and poor food quality. And by poor food quality, I mean, high carb food, out of a box food rather than fresh fruits and vegetables. And
right.
Those things all play a part.
The processed foods. Yes. We like our people to, when they go to the grocery store, we tell them to shop around the perimeter.
Outside.
Yep.
The fresh fruit, the vegetables, the lean meats, and stay away from the processed foods in the center. But again, any kind of physical activity is helpful. Even people that vacuum their house and take short walks to the post office have been shown to have lower risks of diabetes. So you don't have to think about running a marathon. So any opportunity to walk a little bit and eat a little less is going to reduce your risk.
My husband's going to hate me because this is a Jill question. With him, in his cholesterol, the doctor always says, if you just lose 10 pounds, it makes a big difference. Is that true for diabetics, or do they have a higher threshold?
In fact, it does. And again, when we say lose weight, you see most of the effect of weight loss within 5% of the weight. So if you're 250 pounds, you don't have to get down to your high school weight of 170. When you start to lose weight, the body switches to a much more insulin-sensitive, lower glucose, your blood fats go down, blood pressure goes down. It really is quite remarkable. And if you can get through that first 2 weeks, you'll see a great result and have a lot of satisfaction and feedback that you're doing the right thing.
All right, last question today, Dr. Wild. Melissa said, I tuned in late, I'm sorry. You said something about they were opening up vaccine to all adults. I'm in phase 5. Does it matter which state she lives in?
So it does. Kansas, as of today, has moved to phase 5, which is any adult 16 and over is eligible, assuming that there's supply and an appointment for vaccination in your area. On the Missouri side, it is April 9th is the date that effectively coincides with a similar move. So not too far next week, but there is a little bit of a difference. And with that, I think we'll wrap up today. Tomorrow, we have the KDHE Secretary, Dr. Lee Norman, back to update us on vaccine rollout across Kansas, including how we're moving into phase 5 as of today. He will, of course, after that, take your questions. So I'd like to thank everyone for joining us this morning. As we wrap up today, George, any final thoughts you'd like to share with those watching?
Not really. I don't really have anything. I just try to stay healthy. That's all I can do. And if you can do whatever you can to stay away from diabetes, I would definitely work on that. I know I tell my kids out here, do whatever you can not to be diagnosed with diabetes. The things that they're eating right now, out of the vending machine and stuff like that. I tell them, I says, that's gonna come back and haunt you later if you're not eating, properly. And it'll never get me. It'll never get me. I said, yeah, I was that way too. I thought I was invincible growing up. I wasn't, hardly sick a day in my life, up to about 30, 35 years old. And I tell the students, you got to think about your health now rather than wait until later and then find out that you've got some irreversible things going on. So.
And George, you take great care of yourself. It's really an honor to work with you, and you're a great example. And thank you so much for giving us some of your time this morning.
Well, thank you.
And George, I'd say you did great coming up with a couple very important final thoughts there without much warning. I tossed that to you sort of unfairly there. We're used to it here, but you didn't know it was coming.
No.
Dr. Robbins, from your perspective, any other final thoughts?
Get your shot. I think if you're worried about what the effect of diabetes, the best thing you can do right now is get your shot. Don't worry about it. Get it.
Yeah. I would echo that. That is extremely important. And I think our guest, George's thoughts and concerns are not unique, and a lot of people have them. Addressing the first one about influenza, causing the influenza vaccination causing influenza, the influenza vaccine for the injection is a inactivated killed virus. It has been shown not to cause influenza. Certainly you can have other illnesses, and without knowing, the 3 times that he had it and what his total details were of that incident, it's hard to really say. A lot of people will have coughs or colds being asymptomatic prior to getting the vaccine and then develop symptoms. Could it be something else? But it is extremely important. We've done extremely well. We are nearing the end of influenza season now here in the Northern Hemisphere, and it's been really good. We've kept a lot of people out of the hospital and out of the ICU because of that. So those are not unique. We will continue to address those, just saying that it is safe, and it will, even in low efficacy years, it will help protect you from missing days of work, from going to the ICU. And then his second point about the vaccine being safe for diabetes. We heard it here from our expert. All diabetics should be getting that vaccine. You are at increased risk of going to the hospital and having severe illness, so please get that. It is safe. It is just really that spike protein. It's not even a whole virus, so it will keep you safe. It will keep you from going to the hospital, severe disease, and death, and that's what we are looking to try to do. And we will continue to give that message and really promote that as much as possible to keep you and your loved ones safe.
Yeah. And I think I would only add to the get your shot and get your shot final thoughts that, as we look at the map this morning, it's a little bit scary. There's signs again that much of the country has moved into sort of the red zone, if you will, where cases are increasing rapidly. 27 states, I think, as of this morning, having a pretty significant increase as compared to last week. And that's just a reminder that this is not over. So as we close, we will give the final word to Dr. Stites, who reminds us similarly to have patience with this pandemic. While we are closer than we've ever been to getting back to life as we knew it, we need to hang in there for just a while longer. Continue to follow the pillars of infection control. It's not the time where we want to stumble and trip this close to the finish line. So here's Dr. Stites. We'll see you tomorrow.
We are in a wrestling match, and we're wrestling with our desire, and our desire is to get out there and be normal and get together and be social and those things and help make life a lot of fun. And you know what? There is going to be a time and there is going to be a place. But ask yourself this question. If you knew that the actions are going to cause injury and illness to another person who you care about, would you still make the same choice? And I think that's the wrestle you have to do. The wrestle is inside your head. The desire to get out and be around folks versus having to wait just a few more weeks before we can go out and do that and know that the wrestling match is much more on our side. Time, hope, faith, science, they will make us win that match. If you go out a little too early, we're going to watch the numbers rise. And the numbers rise, deaths rise, sadness rises. So be safe, take care of each other, and remember, there's still no place